Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by Icario. Our presenters today are Sara Ratner, Senior Vice President of Government Markets and Strategic Initiatives, and Lora Alexander, Vice President of Engagement and Design, both with Icario. And they will be presenting the webinar, Breaking Barriers, Understanding Medicaid Food Access Through New Data-Driven Insights. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. And now I'd like to pass it over to Sara and Lora.
Great, thank you, Ron. So I'm Sara Ratner. I'm the SVP of Government Markets and Strategic Initiatives within my area. I'm responsible for legal compliance, all enterprise strategic initiatives, corporate development, business development, and partnerships. Lora?
And hi, I'm Lora Alexander. I'm the Vice President of Engagement and Design at Icario. That includes our content and creative teams, our print, our design, research, engagement strategy, and UX UI.
Great, next. So there are various interrelated aspects of social determinants of health, food security, and health, which everybody on this call is aware of. And this is connected across the community, family, and the individual. COVID magnified existing barriers and other pre-existing limitations, and this chart kind of represents that. This shows the orchestration and magnification of COVID on these different areas, especially around those individuals who are already experiencing or predisposed to food insecurity. And this also highlights how all of these different components are interconnected with poverty, increasing the likelihood of food insecurity and increasing disease and chronic condition exposure. Next.
One of the things that I'm going to talk about next is a survey that we recently did in conjunction with Harris Polls. But I thought it'd be kind of fun to have a poll beforehand to see your guys' assumptions and perceptions in advance. One of the questions that we addressed or asked with Harris Polls was, which of these barriers do you find is one of the greatest areas, barrier to access to health? So cost, having access to a provider, technology, location, transportation, and language. And just to be clear, we'll be talking a lot about Medicaid respondents in this, but we also did regular employer-sponsored care and Medicare. We ended up speaking with about 4,000 participants. So if you were thinking about what an average participant might have responded, what do you believe might be the largest barrier to accessing healthcare for these audiences? And this is in the past 3 months, so keep that in mind. So this is post-COVID, certainly for most people post or pre getting any sort of vaccine. So I don't know how long I should probably wait. It looks like they just closed the poll. The results came back. I don't know if you guys can see them on your screen, but most people believe it is cost as the highest amount, followed by location, provider, and then a little bit of technology and language, which would have been, by the way, my guesses too, if you want to change the screen. Fascinatingly, the number one The number one and number two issues nearly tied for Medicaid were technology and cost. So cost, of course, is up there for all of them. But look at the impact that technology and the lack of technology has had on our Medicaid participants in this past year. And as Sara and I started really having an in-depth conversation about it, it makes sense, right? As you think about the co-connection of everything under COVID, the impact technology has on accessing services and providers and food and transportation, you can see where it's also deeply interconnected. Next.
Wonderful. So in order to level set, I wanted to just cover what the actual definition of food security is, because we all define it very, very differently. And for purposes of this presentation, there's two key components. The first is the ability to consistently get adequate amounts of food, but also it's the idea of supporting healthy eating. Between 2018 and now, there's actually been a 63% increase in food insecurity. And originally when I started studying food insecurity, I thought it's probably really prevalent with urban, but actually it impacts rural as a percent of the population more so than urban. Also, food insecurity disproportionately impacts BIPOC populations as well. Next. So specifically, enrollees, you'll see from here, enrollees who are Hispanic and Black reported higher rates of food insufficiency than white enrollees, as did enrollees with incomes less than $25,000 in 2019 and people in fair or poor health. Also, there is a significant overlap in eligibility requirements for Medicaid and federal nutrition assistance programs. But despite this overlap between program eligibility limits, there's really less than half of all Medicaid enrollees who are enrolled in SNAP. So enrollment in food support programs is lower among Medicaid enrollees who are food insecure, which really reflects the unmet need for food support. Next.
So one of the questions that we asked, and we'll talk about it a little bit more, but one of the questions that we asked within our Harris poll was, what is your understanding or belief on whether or not you have access to food support programs tied or related to your health insurance plan? And 44% of Medicaid subscribers reported having access to a food support program through their health plan. 23% said they did, 23% said they did not, and 20% weren't sure. When in actuality, we know that the number is much greater than that. And so it is a problem with perception. It's a problem with communication, and it's a problem with access in terms of knowing how to or where to gain access to some of the programs. And when you couple that with what Sara just mentioned in terms of who's needing it the most and where you're seeing the greatest impact, it's the same audiences that we're seeing in issues in so many different ways, having access to healthcare, having access to technology, and they're also not even aware of the programs that they might have through their health plan. Next.
A very interesting component around food insecurity, especially which was magnified this last year, is global food prices. So food prices have contributed to insecurity, especially over the last year. You'll see that global food prices rose close to 20% last year, which is consistent, very consistent with broad movements of other commodity prices and currency trends. So the US is experiencing high food price inflation at the retail level, with about a 75% inflation increase since 2020. And this is really reflecting lingering supply disruptions due to COVID social distancing measures, currency devaluations, and other various market factors. There is also a decrease in perishable and nutritious food as patterns shift towards cheaper options, with the bottom third spending 36% of income on food, and there being a 78% disparity between the top fifth and the bottom fifth income levels.
And one of the
Also-
other things that we talked
Go
about,
ahead.
Sarah, right,
Yeah.
was the impact on, I mean, we obviously know about food deserts, but if you think about COVID, you're looking at, once again, a deeply exponential problem. So transportation to get to food was also restricted as we saw less and less options, especially early on, in terms of public transportation. The cost went up, but then you also had to pay for transportation to even get to the food. And then if you were somebody who had access to a delivery sort of service, it required an extra fee and technology, which so many of our audiences, as we know and have seen in the surveys, didn't even have access to, or that kind of capacity.
Yeah, you think about the barriers that people have confronted around accessing telehealth. Well, accessing remote food delivery is the exact same thing.
Yep.
Also interesting is we think about the type of food and nutrition that people are getting. Starting in April last year, the outbreaks in the US meat processing facilities led to a severe shortage. So meat prices in May of 2020 rose about 16%. And actually, I read this, it was the largest 1 month jump since meat prices first started being tracked in December 1993. So this increase really caused those that are most insecure to have to shift their consumption patterns to lower cost, less healthy meat and other substitutes. Next. Also, as noted in this chart, food insecurity is most prevalent in households with children than those without children, with reports as high as those during the Great Recession. And we're starting to see these numbers decline with the economy opening up, which is great. Also, schools going back full time helps limit the kids' food insecurity because breakfast and lunch for many kids are provided in schools. Next. So this map represents the diversity in food security, even within short distances. This map is from Minnesota, where we're located, and it's centered on Hennepin County, which includes Minneapolis and the surrounding suburbs. So there's parts of Minneapolis that are very poor, don't have access to great food. And then within a couple of miles, there's, some of the nicest areas of the state. The green here signifies the low barriers to food, with the purple representing areas where there are even really high barriers. And you'll notice on the chart on the far right, there's a large disparity in food security, even within miles, and actually blocks apart, which is striking. Keep going.
There was a question that had just popped up,
Oh,
Sarah,
yeah.
that I'm going to jump in and answer,
Yes.
which was, can we talk about how remote food delivery is linked to technology access? Absolutely. So one of the things that we saw in the spring and the summer was, as we were required to socially distance, and as we closed more and more offices, physical spaces, obviously because being open to the public was dangerous, more and more of those services relied on technology to even organize or to set up those appointments. So we're not even just talking about something like Instacart. We're talking about government programs, and nonprofits often said, because we want to do social distancing, go online to set up your request, go online to set up a profile to say you need access to these services for people who, of course, had limited access to technology to begin with. So it, again, just built on itself and built on itself. And there's a lot of studies out there that have talked about just the difficulties that can be so inherent in technology, which is why, especially in the Harris poll that we showed, for people who have kids in particular, it's again, telehealth, but also education, and also transportation, and also food, and also government programs. It's just tied and tied and tied together. Sorry, Sarah.
Yeah.
Go ahead.
that's one of the reasons why technology is now referred to as the super determinant of health, because this past year really taught us that it is the thread that keeps, kind of everything in balance now. And if you lose it, you lose your equilibrium to access to healthcare, to food, and everything else. So this slide, you'll see that the state healthcare costs are closely tied to food security, with large variations across state and counties. So on average, healthcare costs for a food insecure adult is $1,800 higher than people who are food secure. And the state with the highest cost per capita is Mississippi at $243 per person. So food insecurity policies, or food security policies, are an important mechanism to really contain healthcare expenditures. And we'll talk about that in a second. What states are beginning to understand is that illness in a value-based system, it really cannot be addressed without identifying the social, behavioral, and emotional conditions that contribute to this poor health. Keep going. Interesting is that food security is greater than income in predicting chronic illness. So income is only associated with 3 of 10 chronic conditions. A recent study in this space found that food security is associated with an increased risk of 10 of the most common, costly, and preventable chronic conditions. And this slide and the next list them, but it's hypertension, coronary heart disease, hepatitis, stroke, cancer, arthritis, COPD, and kidney disease. And obviously these are the ones that cost the system the most and create the most amount of burden. If you look at hypertension, you'll see that the prevalence of those with hypertension, of those that are high food secure versus very low food secure. So 19.7% of those with hypertension have high food security, 23.6% with marginal, and 28% with low food security. And as food security worsens, the likelihood of having these conditions also worsens. And this chart also represents that those with very low food insecurity are 15% more likely to have a chronic condition than those with low food security. So it's very low versus low, low being 18% higher. Go on. And you'll see the spike. This is, this is something that you would expect with the last year. You'll see the spike in the chart representing elevated levels of food insecurity due to COVID. And those most impacted by food insecurity before COVID are facing even greater hardships now. Can keep going. So more specifically around this data reflects the overall increase in food security between 2020 and 2021. Overall, the highest rate in 2021 is Mississippi at close to 19%. And on a total numbers basis, the highest is Texas at 4.8 million. The highest percent increase is New Jersey, up to 36%. And the highest total number increase is California at a raw number of 760,000.
And one of the things we should note in terms of children and having food insecurity, you're seeing some impact and you're seeing some actions by the government to try to address it. For example, the USDA announced like last week that they're going to continue the free school lunch program through next year, through the entirety of next year. So there is awareness of this. There's also and Sarah, you're about to get to this, but an absolute increase in the number of health insurers that are adding food programs to their systems. Most recently, Blue Cross of North Carolina had announced that they're partnering with a number of local programs and organizations to help address it. It happened at the Blue Cross in Minnesota. It's happened in California. But this is something that we, as an industry, have to really put our energy into, because it's getting worse. It's deeply interconnected, as we can see, and it relates to how effective. I mean, the food security is directly related to health plan or health care, as we've mentioned. So one of the questions we really wanted to get into is the understanding of the audiences that we were polling on, just where are they aware and who is aware of what food support is available through their health plan, because so many people are unaware. And so we broke it down here, as you can see, a little bit into demographics. Fascinatingly for me, by a large increase, men were more aware or stated that they were more aware of the food programs than women. Little less surprising, I think homeowners were more aware than renters. And then married partners were more aware than non-married. But again, these aren't active numbers on what is true. This is just perception and awareness.
So Laura, we have somebody who asked a question, and the question is, please define health plan food support, and do you mean support above and beyond food stamps? And we'll talk a little bit about the difference between health plan food support and things like SNAP or food stamps for sure in a minute, but they're very different kind of mechanisms to help give people access to nutritious food.
Yeah, I was perfect. So that is going to be exactly where Sarah's going. I think, yes, in fact, pretty much right now. So go ahead, Sara.
Yes. So states are doing a number of different things, and this really gets to the question of like, well, how are health plans doing this differently from other benefits provided by the state? So you've got SNAP, and I'll talk a little bit about that, and then you have Medicaid separate. And in order to fund this through a health plan, health plans have various levers that they can use. The first is that they can classify certain social services as covered benefits under the state's Medicaid plan. Some states allow that flexibility. Also, there's Section 1115 and 1915C waivers. These became much more popular this past year because they allow for food security for home and community-based service types of programs. The 1115 demonstrations also allow, it gives states an approach to test new models in Medicaid that different from what's typically allowed, such as like non-clinical services that are being offered as part of a Medicaid benefit package. And this is where states can kind of carve in and use these vehicles in order to offer food to their members. There are also value-based payments that support providers' investments in social interventions. So we're not only seeing this on the health plan side, but providers are getting into this space too, as they're going at risk more and more. I've also seen states use incentives and withholds. So typically, states will offer pay for performance incentives, or they may hold back a certain portion of the capitated payment. Plans are using the incentives and withholds in order to encourage investment in various social interventions, and one of which is food. There can be other things like transportation and access to digital services, but food is one of the big ones these days. There are also attempts to integrate leveraging resources for these social issues into quality improvement activities. Health plans are constantly measured around quality improvement. There's many reports that come out and that are required to assess the health plans in this space. And so some of the things that we're starting to see is these areas are being called out and flagged as either something that's going very, very well, or areas where there's improvement. Other states have rewarded plans with higher rates actually, and higher investment dollars for these social interventions. And then there's really food purchasing incentives that are offered, that states allow plans to offer in order to encourage beneficiaries to purchase medically appropriate foods. And an example of this is really, we've seen this with diabetics, where states allow plans to offer incentives for the beneficiaries to access nutrition programs that really help manage their A1C more effectively. Also recently, something that I saw, and I think we'll see more and more of, is that states are asking plans to address this as part of RFP documents. And one of the things that we're working on right now is trying to collect which states are doing this and come up with a compendium to see what the trends are, which states are starting to really put a stake in the ground around food security, and what their levers are in requiring health plans to make these investments. Go on.
In fact, Sarah, I
Yeah.
think one of the things we've seen is that it's food security is probably the biggest one, but we've seen it in other areas of SDoH, or other factors around SDoH as well, and things like how are you dealing with individually and in terms of a state, how are you dealing with racial inequality? How are you improving access to audiences and communities that don't have the same kind of access, whether it be technology or food or education? So I think, and we are doing the research right now to try to figure out which states and how it aligns, but I don't think it's going away. I mean, I think that the more we understand the interconnectivity of all of these activities and behaviors and their direct impact on the cost of healthcare and access to healthcare, we're going to start to see more and more. Well, I mean, it only makes sense that we'll see more and more of these things coming forth in RFPs and in communications from the state when they're looking for partners.
Yep. So a component that really was magnified this last year is how people enroll in programs. Obviously, with social distancing and different government building closures, people couldn't walk into a public facility and say, I want to apply for food stamps, I want to apply for Medicaid. One of the components that the public health emergency flagged was this huge area where people are losing coverage because they can't get access to the resources to go through the redetermination process. The same thing on the food stamp side, where people were falling through the cracks. And so there have been mechanisms that are put in place, or at least starting to, that allow states to use eligibility findings from Medicaid to support nutrition assistance program eligibility determinations and vice versa. And also, even in states without this type of integration or data sharing, eligibility enrollment staff for Medicaid and food support programs, they can help refer individuals to the other, which is really important during the pandemic. So if somebody comes in and says, or calls or gets a notice that they're eligible, they have to go through the redetermination process, or they're eligible for Medicaid, states are trying to also make them aware of the other benefits they may have access to. And it allows a bit more of a streamlined process versus something that has historically been disjointed and uncoordinated. But I have to say that this is a trend. It is about half the states who are trying to innovate in some way, shape, or form around this.
And of course, again, you'll note, even in this case, we're talking about online systems, which sometimes can be telephone. So I don't mean to imply that it wouldn't also be a telephone, but it usually revolves around an access to technology and a comfort level with technology that is not necessarily always there in all of our audiences.
The thing that I noticed this last year where there was the largest gap is with duals, because historically duals do not have great digital access, and a lot of their care coordination was done face to face.
Yep.
And so huge gaps have been created. around access to care, food benefits, transportation, pretty much anything that's creating a barrier. And states and plans are now trying to figure out, well, how do we kind of reverse course and, do right by this population now.
So as we talked about earlier, and I put this slide back in here now because based off of what we're talking about. So understanding all of these barriers, it's fascinating to see what level of awareness or what level of lack of awareness we're seeing in our audiences around what access they have to food support programs. Because look at these numbers, and then Sarah's about to get into what some of the plans are actually doing. And there's just a disconnect, whether it be around access to communications around it or just knowledge of what is aware or what is available through their programs. Go ahead, Sarah.
So if you want to go to the
Next, sorry, yeah.
So health plans are doing a bunch of different things, and one was just announced, Blue Cross of North Carolina today. We're seeing these things all over the place, which is amazing and wonderful. But these are just a couple that have caught our attention. So Health Partners Plan has a food as medicine program for duals who struggle with food insecurity. Humana is doing a number of different things, the Well Dine Meal Program, as well as debit cards to buy healthy foods each month. Similarly, United Healthcare has their dual support programs that provide money to assist with groceries. Alignment Healthcare, which obviously is new to the scene and a different kind of managed Medicare Advantage company, they've launched a crisis meal delivery program so that it gives individuals meals at a period of time when they can't otherwise access meal service or grocery stores. Blue Cross Blue Shield of South Carolina leverages the home and community-based service model to provide meals for homebound elderly, the HCBS waivers. Cigna also does post-discharge meal benefits for MA members. And so think about this as a lever to pull as part of preventing a readmission process. We know that food is a huge indicator in people who are going to end up being back in the hospital. And if we can offer those meals post discharge, that really helps mitigate the likelihood that they will end up back in the hospital.
Yep.
And then Magnolia Health is doing some interesting things around delivering at-home meals to MA members.
And the Blue Cross one that we mentioned, the North Carolina one, there's one aspect of it that I found fascinating, which is they are aligning with a local prescription food program where the members get like a monthly stipend that they can pay or use directly to pay for healthier foods, fresh foods, and fruits and vegetables, things like that. So it's some of the stuff that Sara was talking about earlier, where it's kind of targeting behaviors in a positive way, where there can be some benefit to use the funds towards something that's going to help them both financially and health-wise.
One of the other things that I've seen, which to me is really interesting, is how PBMs are starting to take note of how food as medicine programs can really influence med adherence and compliance. And so think of those places where people can buy food as well as get prescriptions filled. We have a ton here in Minnesota, but they're all over the country. And so the thought is there a way to leverage the pharmacy and the grocery store in a one-stop shop where you ultimately help solve a bunch of different problems? You get the person to the pharmacy, first of all, which is absolutely critical, by leveraging the food as medicine program to get them to the grocery store. So that to me is a really powerful way to leverage multiple different components in a system where you create a much more perfect alignment in trying to drive the outcomes that are needed.
And there's one aspect. It wasn't part of our study or survey that we were poll that we did, but it's a study we did independently where we looked at our audiences and our population. And when asked the question, when within the last 12 months, the food I bought didn't last and didn't have enough money to get more. We then counteracted that with what is the average days that physical health is not good, or average days for mental health not being good. And the increase was about, or I'm sorry, of those populations, there was a 10% or 11% actually increase in often, and another 10% of sometimes. So you were looking at almost 20% of the population that says that they don't have enough food on a monthly basis, seeing an increase in physical and mental impact, which is again direct cost into healthcare fees and responsibilities.
I'm just going through, Laura, because we have been completely remiss about managing this Q&A.
I have like 10 questions. I'm so sorry.
Yeah, we do. So there's some great comments. Thanks, John Gorman, for some added commentary. Some other comments that we can either answer live if we've got time, or certainly happy to take down names and respond to. So one of the last areas that I want to comment on is just state and their food benefits. Obviously, a lot of what plans can do is driven by what the states are permitted to do. So you'll notice and reflect on the map that I showed earlier in the presentation, where it showed a very large difference across the country in states and food security and their medical costs. But as you'll note here, states, most states are trying to figure this out in some way, shape, or form, irrespective of whether or not there's low or high food security, and irrespective of high or low medical costs. So Virginia is one state where they, like others, offer meals post-discharge. Michigan similarly coordinates services and referrals for people who are facing challenges accessing food. And that's driven by their Medicaid managed care status and health plan. North Carolina also is working to reimburse food with its Medicaid benefit through, I think it's a 1115 waiver. New York, some Medicaid plans are contracting with community-based organizations to deliver food as medicine meals, especially those with life-threatening illnesses and chronic conditions. You'll see California also, they've got a medically tailored meals program, similar to what I've spoken about earlier. Take, for example, the diabetics, but this one is for people with congestive heart failure. Massachusetts has a food subsidy program that's medically tailored, similar to California and other states. And Iowa has leveraged different waivers to provide home delivered meals for individuals needing it. Laura, I know we've got a number of questions to answer, and I want to make sure that we get to all of them. But one thing I'd love for you to comment on before we open this up for questions is, we've seen mental health it's in crisis mode right now.
Yep.
And we think about mental health and food differently, but there is such a convergence of and magnification of these problems at this point.
Yes.
Can you talk a little bit about what we've done in that respect and how we've looked at it?
Yeah, I mean, one of the things that we're doing is as we start to build on the direct impacts of COVID and what has happened in the past year, we've been aware and concerned with the mental health impact and tie into SDoH factors for a while. I don't mean to imply that that's something new, but the exponential growth in the last year has been pretty astronomical. And so we've been doing quite a bit of research, obviously some secondary research, a lot of research within our data and analytics. And that's the kind of stuff I was talking about earlier, where we're seeing 20% increases in people who indicate that they don't have enough food, saying that they have had either severe or common mental health activities increases in the same month. But we're also starting to do some primary research to try to figure out what we like to say internally, which is the why. So talk to us about what does it mean? So if we have a direct conversation with somebody, and right now, of course, it's still through technology. We have not reached yet a point where Sara and I can go out on the field and sit down and talk to people. It's coming, but it's not quite there. But in the conversations that we can have, what is the direct tie-in? So what causes that mental health impact? Are there things that health plans that can do that are, of course, within the food insecurity space, but are there other factors that we can do to tie in together? And some of what we're seeing is early, it's very early, but again, it's tie-ins to things like technology. So the inability to access so many different resources and the shifting position that people find themselves in, just all of them amplify the impacts on mental health. And so we are attempting right now, we're building out some products to help support people in their mental health situations, where then it can be anything from this is normal, this is what's happening to people, this isn't something you should consider to be shameful or something to be embarrassed about, all the way to how can you impact it and what do you need to look for in yourself and in your family. So there's a lot of direct correlation. There's a lot of direct engagement between SDoH factors and mental health. And it's just a step above regular health, which we already, of course, knew.
Yeah, an organization that I think is doing a pretty good job of this is CVS and Aetna, with the work that CVS is doing on social determinants of health, and with Cara McNulty's leadership on the behavioral health side, really trying to figure out how do you tie this all together, because it's one big messy problem. And there's no perfect solution, but they're working and churning towards some very interesting ways of handling this and setting the stage for different models to come.
I will say that in terms of mental health, which is, of course, just yet another factor, so we don't mean to highlight it only, but the exponential growth of people who are saying that they are having mental health impact in the past year is pretty incredible. I mean, I don't think we've ever seen growth like that in 1 year. And it certainly is going to have a very direct impact on our health plans and our partners and how they do outreach and how they help these people who have never been part of a mental health crisis or even treatment in the past.
So as we're wrapping up, I guess one of my observations, and Laura, I'll turn it over to you as well, is, historically healthcare has been transactional. We've treated things in buckets, and you go to the doctor, it's a transaction. You get your prescription, it's a transaction. You get your food, it's a transaction. And so we're at a tipping point, and I know we're really focused on this, where we're trying to tie it all together so it's seamless, and the thread of how to maximize somebody's access to healthcare, that thread goes through everything, and the handoffs are seamless. And you're not letting somebody fall as a transaction, but you're kind of helping guide them through the process more so than ever.
And I think the thing that has stood out to me just so intently is how interconnected everything is. So you reduce, or people feel a reduction of access to food, and it has a direct impact on healthcare, and access to technology having a direct impact on transportation to food access. It's just one big interconnected soup. And if we don't address the big parts of it, the smaller ones will continue to be a problem.
So now I think we can open it up for questions if we haven't addressed them already. Would love to answer anything that's on people's minds.
Sure.
There's commentary as well, things that people are seeing or doing. We'd love to have that fed into this as well. And yes, these slides can be made available.
Yeah.
Okay. Why don't we just start going down the list of questions? For example, do the cost of these services typically apply to the medical loss ratio?
It depends how it's structured. Typically not.
Okay. Do you know which states are offering incentives for using food access for diabetics? And is that through health plans?
I wish
I don't know that we have a list particularly about diabetic food programs. Do we, Sarah?
We have a list. It's on our website. We published a list of, kind of various things states are doing in the social determinant of health space. And there's one column that has food, I believe, but we have not flagged those states that are specifically focusing on diabetics.
It's a good question, though. I would imagine that, as we all know, diabetes is a great cost. It's of high cost for most of our payer audiences, and it's also incredibly related to food. So it's probably out there. We just don't have that research done.
Mm-hmm.
Next question, are these covered benefits by Medicaid, Medicare, or are these plans deciding to cover above and beyond benefits that are set?
They're typically wrapped outside of the benefits.
And often in partnerships with local organizations.
Yeah.
Non-related outside organizations.
Yep.
Okay, next question. Are there state food programs for elderly, like WIC is for women and children?
Yeah, a lot of the home and community-based service programs are for elderly, and those, a lot of them offer home delivered meal programs.
Right. I was just going to say things like Meals on Wheels and other programs. It doesn't have to be just tied to that one. Are prevalent in some areas. I will say for many of these, they become less aware, or they're less prevalent when you get into more rural areas. They're a little bit more sparse, but.
Yeah, if you remember from one of the first slides, we said, as a percent of the population, this impacts rural more than urban. And I think something to consider for this audience is that when we have these food and meal delivery programs, it becomes very difficult to reach rural America. And so interesting to think about how the industry can help support that in a greater way, because that population is really kind of left off to the side and often ignored, unfortunately.
Yeah. And we, of course, we don't mean in any way to imply that the lists that we're giving are what is the word I'm looking for? Exhaustive or complete. We're giving examples, but I will say that the research consistently shows that you're more likely to be aware and have access to programs if you're in an urban area, which of course makes sense in terms of coverage.
Mm-hmm. Ron, are there other questions?
Certainly. Especially as states start to include food and other social determinants of health programs into their normal benefits and rate setting process, what do you see as the best way to transmit the data for those transactions? Meal delivery, housing.
Do you mean, I just want to ask, do you mean by transmit the data like on who is participating and who has access, or just how do you get the information out to the audiences? It's two different answers, I think.
How do you get the info? Is what he's asking.
How do we get the information of people who are facing these issues? I'm sorry, can you repeat that? I'm not sure that I'm following the question.
It said, what do you see as the best way to transmit data for those transactions? Meaning, how do you get that information?
How do you find out people have participated? It is difficult. It is particularly difficult when you're partnering with local organizations who don't have the capacity or the ability to like track how many people are coming in and feeding it back to the payers. It's beyond their capacity, and certainly beyond their staff.
Yeah, unfortunately, the systems are still antiquated, and a lot of this is done manually.
Yeah.
Okay. Is there any preference for food health plans to purchase frozen meals versus non-perishable foods?
I think that's really more of a food sustainability issue.
Right.
I'm not an expert, I would say it's probably the biggest benefit is to purchase foods that are the healthiest and that will last the longest.
Right. I'm sorry if you're watching my face. I'm trying to read. I'm in my head. I'm rereading study after study after study, and I don't think I've ever read anything that targeted out frozen versus non. It was always around fruits, vegetables, fresh if possible. But then there's a lot of research out there about food deserts and the inaccessibility of some foods, and in those cases, they talked about trying to get frozen healthier foods, but I don't think I've seen anything where they've done any sort of either research or targeting one toward the other.
I think one company that's done a little bit in this space is Schwann's,
Yeah.
because they operate out of Marshall, Minnesota, very rural, and have they have a frozen food service, and so they've invested a bit in trying to help the underserved population, but they don't have full scale programs that are offered to Medicaid beneficiaries.
Yeah.
Okay. We have had a couple people ask about seeing the questions that are being asked. Questions are being typed in on the Q&A screen using the icon at the bottom of your Zoom window. Those questions do show up on the panelist screen, but they do not show up on all the attendee screen, just so people know. They were asking why can't they see the questions. So that's the reason. And our next question is, what programs do companies like Icario run related to this issue?
Do you want to go, Sarah, and then I'll
Go
supplement?
Go
Oh,
ahead.
so the ones that come to mind, there's several. I mean, there's a lot. We do everything from surveying people for health plans initially, just to try to get our finger on the pulse of what how are they food insecure? Do they have what is the interconnectivity? We do SDoH surveys, things of that sort. But another big piece of it is the communication, I would say, which is so many health plans have talked to us about the fact that they have these programs and people aren't using them. And so we do a lot of different targeted communications, multi-channel, omni-channel communications out to their audiences to try to engage them in some of these programs, either with just different targeted, specific, distinct messaging, communications to say these are things that you have access to. In some cases, the plans will have us do the survey to find out who is in most need and then target communications to those audiences. And then in some cases, we've even gone so far as to do some attestation where we can go back and say to the plan, these people have opened the emails, have listened to the IVRs, have done whatever. We are also working on a couple of programs right now with some of our clients around what they would like to do to, I don't want to call it just incentivization, but engage these populations. One in particular around technology, which Sarah and I are super excited about, which is we have some plans who are working with their Medicaid. It's mostly Medicaid, I believe, Sarah, I might be wrong, but Medicaid populations to say, if you're engaging in these programs and you do your annual physical and whatever, we'll help you get Wi-Fi into your home and access to technology in your home, which is great because as we just saw, it does so many, it's so interconnected to so many other areas. And it's for an audience who find technology to be outside of their their capacity. And in some of these programs and some of these locations, it's a very inexpensive $10 a month that either the plan can cover or that the member can cover, but we can help them get it into the home. So there's even some programs like that. There's also some research that we've been doing in partnership with some of our plans to figure out what their audiences need in particular. So around food insecurity. So we can do research and are doing research with plans to say, what do the clients need the most around food insecurity? What do the clients need most around technology? What do the clients need most around transportation?
Mm-hmm. The other thing I would just layer onto this are mom and baby programs.
Yes.
We know nutrition is absolutely critical for mom and babies, and our mom and baby programs have a component that deals with the food security issues that prenatal and postnatal mothers and babies address. I guess relative to Icario, if you take a step back, one of the most difficult things to get populations to engage in these programs is the barriers to communication. How do you get in touch with them? How do you reach them? How do you reach a population that is digitally disconnected? And so, what we've done is a lot of research in Lora's space on how do you create a bridge to getting that population engaged. And one of the things is cultural. So if we're reaching out to a population, we have to also understand the cultural sensitivities around food and that population, not just a disease state. And so there's a lot of different factors. And when you're thinking about just calling somebody, it's not that simple. There's a lot of layers to it. And what we've been successful at is trying to understand those layers, factor them into our method of outreaching to somebody and getting people to actually engage rather than just dialing or sending, text messages.
Yeah. We have a great research department that is focused on a number of things, but the member is the end goal of what they're focused on. And it's literally around things like, how do they want to receive communications? How do our audiences need to hear about things so that it'll be the most impactful and engaging for that audience?
Any other questions we can answer? If not, our contact information should be out there, and we'll circulate the presentation, and we're also happy to take questions or calls offline too.
Okay, it looks like we've taken care of all our questions for today.
Yay.
Wonderful.
With that in mind, I'd like to thank Lora and Sara for a very informative webinar today, and thank all the attendees for taking time out of their day to join us.
Thank you for having us.
With that in mind, thanks a lot.